Welcome everybody to our guest speaker portion of the Fuse Public Involvement and Engagement Group, with PIEG as we call it for short. We seem to have a lot of long terms in this introduction. We're delighted that you could join us this afternoon, so welcome. Just before we get going with the talk, I'll give you a little bit of background to the Fuse PIEG. So it's a quarterly meeting where we discuss all things public involvement and engagement. We act as a resource to provide public involvement and engagement expertise to Fuse. We work with research bodies such as NIHR School for Public Health Research, NIHR Applied Research Collaboration for North East and North Cumbria. We also work with voluntary organisations Network North East, probably more commonly known as VON, public partners and local third sector organisation Connected Voices. The PIEG's co-chaired by me. I'm Pam Graham. I'm Assistant Professor in Community Wellbeing at Northumbria University. And I work alongside Victoria Bartle, who's our Fuse public partner. Today, we've got the pleasure of welcoming Dr. Kate Sykes to our meeting, who's an Assistant Professor in Community Wellbeing at Northumbria University. Kate's going to talk to us about her work around public involvement and engagement in research. And then there'll be a chance for questions and answers and discussions at the end. So without further ado, I'll hand over to Kate.
Thanks, Pam. Hi, everyone. Firstly, thank you for asking me to come along and do a presentation on this. It's something I'm really passionate about, so I hope that comes across in what I'm about to say. And my disclaimer is, this is my way that I've approached involvement and engagement. So this isn't by any stretch of the imagination kind of gold standard. This is just how I've muddled my way through it, navigated the different guidance and things, and how it's worked in practice. So hopefully it'll be useful to you all. As Pam said, I'm an assistant professor. For what I say to myself when I'm working with people with a learning disability, I'm a teacher and I'm a researcher. So that is my job. I have two hats. So today, hopefully, I'll share some of that wisdom that I've learned over the years. So Ella's going to try and keep me to time. I do have a tendency to go off on a tangent. So I've got four kind of main elements. So I'll talk about cancer screening, cancer prevention, my research studies that I've been involved in. Oh, I'm getting a bit of feedback, sorry. And the PPI I've done to date. And then I'm going to talk about, again, something else I'm really passionate about, which is easy to read information and the principles behind that, because I think we all should be using them principles regardless of who we are and who we work with and who we speak with, and then open that up to questions and answers. So if anyone has any feedback, please do share. So firstly, cancer world and a lot of my research is around cancer screening and cancer prevention is split under these two kind of brackets. So we have cancer prevention, which is the images on the right hand side, which is around healthy activity, healthy eating, limiting smoking if you do smoke, limiting alcohol consumption, all of them things that we know can help prevent cancer from developing. But then we also have the cancer screening programs that happen across the globe in one way, shape or form. And within the UK specifically, we have the three formal national screening programs. So they are for breast cancer, cervical screening, and then bowel screening as well. So they're the three kind of overarching programs. And you'll get invited to them at different ages. And there's different criteria for invitation, and I didn't want to kind of go into detail about them today, but just to differentiate between the two elements, that screening is different to prevention in a way, although screening does prevent, in a way, some cancers, especially cervical, which is now testing for HPV, the HPV virus. So again, it's the two very much do blur. So the three kind of projects that I'll be sharing are presented on the screen. So my first one is my PhD, which looked at barriers to women with a learning disability accessing cervical and breast screening. And that was 2017 to 21. And that then led on to a funded ARC project, which again looked at learning disabilities, but also then looked at people with severe mental illness, so people living with schizophrenia and people living with bipolar disorder, because we know there are similarities between the two populations in terms of barriers and problems that they face in accessing screening programs. So it kind of used my PhD research as a lever to then build upon that and kind of look at severe mental illness in a little bit more detail. And the website to the project is there. And kind of moving on to now, that has then also led on to another bid, which is, keep fingers crossed, we're waiting for a decision on, which is looking specifically at breast screening, but across 7 different populations, again, to identify what are the barriers and enablers for people in deciding to go to screening or not go to screening, because a key thing to remember with screening is it is a person's choice whether they go or not. But what we tend to see, oh, why have I got a thumbs up on my screen? But what we tend to see within kind of screening world is there is a choice element, and often that choice is hindered for some people because of information isn't provided to them in a way that they can understand, apply and use. I'm going to go into a little bit more detail about that. So what I've done over the next few slides is really highlight what patient and public involvement and engagement I completed over them 3 separate projects, because it does look similar in some ways, but it's also different. So in terms of my PhD, I had no funding for PPI, which I think is probably a common barrier that is discussed within this group around the lack of funding for PPI engagement and involvement of people. So thankfully, people were willing to speak to me and wanted to help me to inform this work. So we developed a survey that went out to 10 women within a local support group, and their facilitators facilitated their engagement in completing that survey. And the survey focused on how the women wanted information to be presented. So was it cartoon images? Did they want real images? Did they want it in size 20 font or size 16 font? Did they want it in Comic Sans style, or did they want it in Times New Roman style? Really to get their involvement within that, because we know that there are easy to read principles, which I'm going to go through later. But actually it's still people's preferences. So I got their perspectives on that, and then informed all of my data collection documents based on them perspectives. So following the survey, I then made all the changes to all of my data collection documents, and then went back to another 2 women who completed step 1. Again, to just check that I had understood their preferences correctly, and again that they could really decide in that conversation whether they were happy with some of them changes that I made, because it's very different having a preference and an option, but then seeing it in front of you often was like, oh no, I don't actually like that. I prefer it that way. So that was really useful to me. And actually, in that conversation, it became really clear that some of the people that we'd spoken to didn't actually know what cancer screening was, that they didn't know what some of the words meant. So I was using the anatomically correct terms that we use, so cervical and breast, but actually they didn't know what they meant. So we had to do some work around what terminology I should be using. And again, I'll pick up that in a few slides' time. So did all that work again, went back, refined it, used their feedback, and then I took them kind of final documents to a separate group of women in a different location in the region. So I went to speak to 6 women in Newcastle to again get their preferences and kind of consensus around, have I understood this correctly? Do I need different versions for different locations, and that type of thing? Because what the kind of 10 women in the first 2 steps, they were all from Teesside. So again, there might be something there around terminology, and different dialects might have different preferences. And I really wanted to check that out with it being a Northeast based study. So lots of work went into my PhD before I even got any kind of empirical data. But what I've done with the PPI phase is I've used that, and I did class it as data collection, because actually I involved lots of people who ordinarily, before speaking to me, hadn't been involved in research before. So that was really interesting for me, and I really wanted to capture that. That ethos that I had around involving people from the start then followed on to the study that we've just finished that got funding from the ARC. And again, we started the involvement from day one. As soon as we had the idea for putting in a bid, we spoke with somebody who has bipolar disorder, and really got her input in making decisions on how the research should look, how it should be run, how many meetings we should have, what should we call them meetings. So she became a co-applicant on that research bid, and she also then became one of our advisory members throughout that process when we did get funding, and helped recruit our research associate for that. So she was part of the interview panel for that. And like I said, we did then have and set up a PPI advisory group, and that was the purpose of that was to have involvement all the way through the research process. So it wasn't a tick box exercise to inform a bid, it was true engagement all the way through, from bid application writing to document checking to data analysis and through to dissemination. Obviously, within that, PPI members were paid for their time, so we were able to do that and really involve people because we could pay for their time, being a bid that was awarded. And kind of moving on from the actual data collection, the PPI members have been involved in co-producing recommendations from that study, and also attending conferences and being writing blog posts and things with us as well, to really share their experiences of being PPI members, and I'll talk about that again in a minute. In terms of the bid that we're waiting for, again, exactly the same ethos, because it worked so well with the PEC study. So we've spoken with people who have lived experience to develop that proposal that we're waiting for. And we've also spoke to a GP as well to gain their clinical expertise, because part of this study will involve healthcare professionals as well. If we do get funded and keep everything crossed that we do, again, we will have a PPI advisory group of 14 people, representative of the 7 groups. So the 7 groups are learning disabilities, severe mental illness, LGBTQIA+, Gypsy traveller communities, people from Black ethnic minorities, and people within the prison and criminal justice system. I think I'm missing one, and that's really bad because I can't remember it. But yeah, there's seven groups. And again, similar to the PEC study, they will be attending meetings, reviewing documents, developing keywords, doing data analysis. Whatever they want to do, they will have the opportunity to be involved in as much as they can. So this is just an example of what our PPI advisory group from the PEC study have been involved in to date. So this is a poster that they had true lead on, that they presented at a conference about their stories, why it's important, what the key messages are for other researchers trying to do PPI. So that's kind of that recommendation section there. Because actually what we found was we were doing more engagement and more involvement than we actually planned to do, because the PPI members wanted that. So we had regular check-ins. How are you doing? Did you get that form filled in? Do you need a hand filling in that form? So really supportive environment, which we learned was so fundamental in making that research study a success. And there was a real thing here around feeling valued, that actually they were a member of the research team. So yes, they were part of the PPI advisory group, but actually they were part of that core research team doing this study day in, day out. That is an image of our co-production session where we co-produced our recommendations for the study. So We had tea, we had coffee, we had big flip chart papers, and it was really good to all get in a room and talk about the study and really co-produce that. So not just us as researchers actually living and gaining the perspectives of people who try to navigate these systems on a weekly basis. And from that, we then commissioned these infographics, which are on the next two slides, by More Than Minutes, to really highlight our co-produced outputs for them. And actually, this is what we've been sharing with people as part of our dissemination plan. So sending it to clinicians, people who work in screening. So actually, that's much more impactful than me sending a copy of our paper that's been published, because you can clearly see the main factors on the screen for cervical and breast. And then this is the one for bowel screening. So again, all of the information that's been on the screen has been driven by our data, but then also co-produced by people with lived experience, which I think is just so important. So what I kept coming back to all the time within my 3 kind of research studies is around accessible information. That obviously in the world of learning disabilities, easy to read information is a given, it's the norm. But actually, what I tried to ponder is actually, should information in an easy read format be given for everybody? And that's something that I'm moving on towards now, is that easy reads, for those that don't know, are simple sentences, jargon free, easy to follow. They have pictures that support the writing, and it helps people understand the information. So we're getting rid of all of the unnecessary information, all of the medical terms, and putting it into language that people can actually pick up, understand, and use. And again, there are just 3 examples on the screen of where to find easy read information. So they have them for the British Heart Foundation, cancer, and these are easy reads that are for anybody. People have that perspective that easy reads are just for people with a learning disability. They're not. Because when we think around that, the majority of people in England have a reading age of between 11 to 14, and yet some of our letters and information that we send to people are much higher than that, then we're automatically causing a barrier to accessing healthcare. Especially when we think that 7.1 million adults have a reading age of below 9. So you might as well have not sent that letter in the first place. So I think it's really important that we think as a system that easy reads are for everybody. They're not just for people with a learning disability. That actually, I use easy reads all the time. If there's a policy that's been published, I'm finding the easy read version, because it cuts out all of that unnecessary information and it gets straight to the point, which again, we're all very busy people. So might easy reads be a way of us to do that, to make it easier for everybody to navigate these systems. And easy reads are just one way to make information accessible. So yes, it's a principle, but actually having information in a larger font. So again, in university world, it's size 12 usually, but actually some people just can't read that. So having information in a bigger font could just help somebody. Having audio recordings of meetings, having audio transcripts or summary notes instead of it being a written document of minutes, again, can really help somebody follow that written information, especially people who have a learning disability, but also people like myself who have dyslexia. So you might have noticed spelling mistakes. I've noticed them as I've been going. But audio really helps me as well. So again, that could be a way that we can make information accessible. And then there are other specific systems such as Macton, Braille, sign language, which are more specific. But there are certainly principles that we can adopt all of the time. And what you've kind of got to think is easy reads is on a continuum. So we have easy reads at one end and our standard text, so the things that we get from the doctors, things that come out from kind of the NHS, they're standard text, but we also have plain English in the middle. And it is a continuum, and different people are going to need information in slightly different ways. So it's useful to think about context, who the audience is, because actually people might just need information in a plain English summary as opposed to it being a true easy read. But it's really important, and what I've learned throughout my journey to being a researcher is co-production is key when making accessible information. That what is accessible to me is potentially not going to be accessible to Pam or Ella or Leslie or anyone else in the room, because it is truly person specific a lot of the time. So we can make the best resource in the world and still somebody might not be able to access that information. But through co-production, we can make sure it is getting there. It's getting there to meet the needs of the majority of people. And it's really important that we think about that. And because that person is the expert in their lived experience, they're a person living with that condition or trying to navigate the healthcare system as a person. So they know that better than anyone else. So this is just an example from my PhD about word checking. So again, as academics and researchers, we get told to use the anatomically correct terms. So cervical, breast, consent forms, self-examination, procedures. But lots of the ladies that I spoke to did not know what them words meant. So we had to have a really long conversation around, well, what is a self-examination? Okay, the checking. So let's just put check. Why do we need to put self-examination? Procedure. So that's steps. You have to follow the steps to get towards the end. And the list is there as well. Probably the most controversial one is cervical and breast. We changed to lazy bits and boobs. But again, they were the phrases that the women understood most. So that's why we went with that. And again, this is just an excerpt from my invitation letter. So you can see how we did use anatomically correct term, but then we also used the more colloquial local language that the ladies wanted. So when we think around easy reads, it's usually presented on A4 slides. The text is aligned on the right-hand side and images on the left. So this is how I've adapted my slides as well. You might have picked up on that. So it's always in that format. The style, it should be minimum size 14, but ideal font from the guidelines says it's 16. And it should be font style that doesn't have that little line. So text such as kind of Times New Roman, because it has that little serif at the top, that's not accessible to people. So using Corbel or Arial is the usual font style. Bold keywords is a great thing to do. Use numbers instead of words. So use the number 3 instead of the word 3. Use do not, cannot instead of don't and can't, which again in the north is what we tend to do. Bullet points and subheadings are your friends, so use them. And keep each sentence as short as possible. So the kind of golden rule with that is below 15 words per sentence. So if you're going to continue a sentence or put a comma, put a full stop and start a new sentence is kind of the rule that I live by. And the language should be simple and simple to use. So any necessary complicated words which we get, we might have to include. They should be explained as much as they can. So this is just an example from the bowel screening invitation letter. So again, the bowel screening kit is there on the screen, and that is an excerpt of what you would be given as somebody who's invited for bowel screening. So I'll just give you a second to read that. And just as a comparison, this is an easy read invite letter for the exact same procedure. So you can see straight away, the pictures make it a lot more accessible. The layout is, yes, bigger, so the document will be bigger, but you're getting the key information within that. And you've also got them very clear numbers there for support. One of the kind of principles that we go by is there should always be a picture within easy read documents. And now whether that is a photograph or a cartoon is dependent on the owner and the maker of that easy read document. We are seeing a lot more pictures and real pictures being used. But you've got to think of your audience. If you're developing an easy read for younger people, children, adolescents, maybe cartoons are better. So again, you've got to think about your audience a little bit as well. And the key with having a real picture is because of this ladder. So this is what's called the symbolic understanding ladder. So the easiest thing for us to understand and comprehend as humans is the real thing. So having a actual banana is the best thing to do. It's the best thing for us to see because we can know that's a banana. It gets more abstract and harder to understand the further down this kind of ladder you go. So cartoon images are kind of the bottom of that ladder because they are abstract for some people to understand. So to end, I know this has been a whistle-stop tour and I've kind of given you so much information. I want you to think about this scenario. So you are waiting for an appointment letter from your doctor. The letter arrives in the post and it is in an easy read format like this on the screen. How would you feel? Have you received information like this before? So again, I just want you to think about that. And again, if anyone does want to share their answers to that in the Q&A bit, please feel free. But yeah, I just really wanted you all to think, how would I feel if I got that in the post without being asked and just given that information as standard? So thank you for listening, and I hope that you are with me on the journey around easy reads potentially being beneficial for everyone. If you want to know more, my email address is there and I welcome any questions or feedback or comments. Thank you.